I'm Lucy, but I'm representing Pumeza. I don't speak Xhosa, so I will just get on with it and just feel the power of Pumeza talking through me, because she is the one who really leads this particular program I'm going to talk about. So I will tell you how we developed an MSF HIV positive youth intervention and how we started. We had to find ways to do things differently, and so we had to listen to the young people to see how to move this. So we began to understand better their needs since quite a while, and we're doing this 7 years later. So, oh, it's not moving. It's getting frozen. Do I need this? Because I speak quite loudly. Okay. So this is Khayelitsha in Cape Town, South Africa. The population of South Africa is largely made of young people. 66% are below the age of 35, with a high HIV incidence and prevalence in youth. Overall, in South Africa, we are struggling to reach the 1990 with only 40% of HIV-positive youth retained on ART. Khayelitsha has one of the highest HIV prevalence in South Africa, with an antenatal prevalence of about 31% in 2015. So this is a picture of the township. The population is about 500,000, of which more than half live in informal dwellings. Unemployment rate is very high, at about 38%. MSF has been involved in Khayelitsha since 1999 with the rollout of PMTCT and later of ART. And from day one, we have been closely working with other NGOs, the Department of Health and the City of Cape Town. So we started interventions for youth in 2001 in partnership with the City of Cape Town in 2 different clinics. There was a Site B and a Site C youth offering youth-friendly services, facility-based. We quickly realized that both testing youth as well as retaining youth in care was a big problem. So this led to developing facility-based youth model in 2012, which showed very good retention in care and very good viral load suppression figures. But this pilot led to the youth care club model, which is now rolled out in South Africa. So through listening and working with youth, we came up with the idea of community youth clubs, moving the facility clubs closer to the people, to the community. I will now walk you through the experiences using the principles of or the building blocks of differentiated service delivery. So in the what is the packages of care. These groups originally started in clubs in a health facility, and some have been more than 5 years at a facility youth club and graduated to the community. They're now mentors and role models for others. To move to the community, members of youth clubs have to have been in facility clubs first for at least 2 years and stable on ART. A group of about 15 to 20 HIV positive young people aged between 20 and 25 meet regularly to receive the packages of care. In these community clubs, young people can access both psychosocial support through a counselor or lay counselors, facilitators that lead sessions through various topics, including sexual and reproductive health and safer sex and positive sex, as well as HIV-specific topics, adherence, viral load sessions. They also receive medical services such as pre-packed ART refills, as well as the possibility of a medical consultation to integrate the sexual and reproductive health services. Women, for example, can get family planning at each visit. So we're still focusing very much on HIV and TB, but the strengthening of the sexual and reproductive health and rights package has been an essential need that we've had to respond. In the WHO, this has been the key to the adaptation of what we do, because it is who provides these medical services, or who provides these services has been the most important. So we aimed at listening to the voices of youth, because they allowed us to have access to them and understand them. We then trained and sensitized the nurses and doctors, counselors, drivers, clerks, and security guards, and to learn how to be friendly and how to be, youth-friendly. Social media platforms have also been used as an alternative to face friendly approaches. We also have developed a social media app that I will show you later, maybe, if we have some time, for a little taster. So we have mentored youth peers, valuing mainly their experience and motivation versus formal education, to be able to support the peers who live in their neighborhoods. Youth peers help us mentor other peers, as well as trace youth defaulting from youth clubs and do the health promotion for this. So if someone cannot attend a youth community club, a buddy can pick up their medication, and this can be done up to 2 visits. If there's a third missed appointment, then that visit needs to be face-to-face in a health facility. So those who don't turn up are usually followed individually by peers in the same living areas. This is done by a kind of visit and a check if they're okay, and this is something that has been trained by the MSF teams, how to be good peer supporters. The groups tend to be attended by more females than males, so we still have some more work to do with engaging young males. And just so you know, in this intervention, we don't really identify youth, bisexual, or gender orientation, and it's not because we don't see the importance of this, but it's because we still don't know enough how to do this, and so we need to learn more how to do this still. So our friendly nurses are NIMART trained, which is in South Africa means that they can initiate and manage ART. They provide clinical support for HIV/TB services, as well as providing family planning. STI treatment and pap smears are done at the facility. More complex cases are usually referred to the facility. So the where is that we have moved to the community, which is usually a community hall, because youth suggested it would be more friendly and a more friendly space for them, easier to access, no queue, less stigma. So this community hall is often used for others, for trainings, churches, and it is a City of Cape Town space, so we don't need to pay. And it is next to a taxi rank. It has toilets, chairs, and a large space, a kitchen. We transform that kitchen into a kind of clinic, confidential clinic for family planning, draw bloods. We take bloods, we do all the clinical stuff there. We carry the folders and medication there in our medical box, so it's kind of like an outreach regular clinic. We also provide sick note letters, because many youth need to have this to kind of, present to their either schools or work, a bit of an absence time. It is a confidential and secure space, and no one can see what's going on inside. And we do these twice monthly for the same group. There are 5 groups at the moment, and each group has their own meeting day. And we carry out these in the mornings, because this is what they have told us that it was most convenient for them. So people generally stay in one club, but if they want to switch, they can. Clubs are run for 1.5 hours, and youth choose the timing related to their work and school timing priorities. If you're absent on your day, you still have 5 days of grace to go and see the same nurse or counselor that you would have seen at the community. But if you miss that timing, then you're deprioritized and you need to queue like everybody else. So there's a kind of drawback if you don't maintain the rhythm. But that was the data and outcomes, and it's about to finish. So the results of our intervention show that it's a good model for this type of context. At 1 year, we compared youth from 3 different groups, one from a facility-based group, one from the clubs, facility clubs, and one group from the community clubs. So at 12 months, 88%, most of the community club clients were still in care compared to 87% of non-club patients and 95% in facility clubs. Viral load completion was 100% for community club patients compared to 84% of non-club patients and 97% for facility club patients. Viral load suppression was 100% for community club patients compared to 88% of non-club patients and 92%. So our lessons learned were that community youth clubs can provide integrated HIV care and SRHR services to youth. Psychological support is vital. Community youth clubs show non-inferior results to youth facility clubs, and challenges in running community youth clubs can include availability of transport, need for dedicated nurse, as well as good planning of services. So for more information on this particular model, please check on Thursday, the 5th of December, there's going to be a poster for you to look at. But also, you could see KETA, which is a digital HIV counseling platform for youth that was launched yesterday, actually. That if we had time, we could see this too, do you think? For 2 minutes, no? Anyway, so we cannot do this without the help and involvement of young voices of Khayelitsha and the caring and professional support of the MSF staff involved in the project. Neither actually from the support of the Ministry of Health and the City of Cape Town and other CBOs and NGOs in the region. And we would like to acknowledge the guidelines and tools we have used and revised from other stakeholders as well. And just to finalize, this is a quote of one of the youth that participates in the clubs, which is, the club made us be sisters and brothers. We plan to do things together, and this is something I never thought I'd be part of.